Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. I apologize that we're starting a few minutes later than usual today. We had some technical difficulties, but we are happy to be here now. For the next 20 minutes or so, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we will offer these 30-minute briefings regularly on Fridays at 12 p.m. During the summer, as you've heard me mention in previous briefings, we're shifting to an every 2 to 3 week schedule. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Brian Garibaldi is director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give an update about treatment of COVID patients. Second, Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'm now going to turn to each of our experts for a brief overview. Brian, first to you. We're hearing that case numbers and hospitalizations are slowly increasing, unfortunately, throughout the United States. Is that observation consistent with what you're seeing in the hospital?
Yes, Lane. Unfortunately, it is true. I mean, if you walk to the hospital, I was just visiting some of our residents this morning, and there's definitely patients in the hospital, and there's more visible signs of isolation rooms being used for. Here we've seen a doubling of our number of patients over the past 3 weeks, and we're also starting to see a rise in ICU cases, and that's in a population that has close to 60% of people are fully vaccinated in Maryland, which is better than many other states. So you can imagine if we're starting to see a rise in cases, what's happening in states that really lower number of people who have been vaccinated. In general, what we're seeing is similar to what the national data shows, which is that 98% or so of hospitalizations right now for COVID are in people who have not been vaccinated, and virtually all of the deaths that we're seeing are in patients who have not been vaccinated. And I think if those patients or individuals who have not yet gotten vaccinated, I would really encourage them to really pay attention to this data. We really are seeing a much different experience among those who are unvaccinated. And if you're not vaccinated yet, you really need to look at examine your decision there, because right now the folks that are getting sick and dying from this are those who have not yet been vaccinated. There has been some encouraging news, I think, along those lines in terms of protection for that I'm sure Bill's going to talk about. There was a nice study that came out of the New England Journal this week showing that people who had gotten both of their of either the Johnson & Johnson or had much better protection against the Delta variant than if you only had gotten a single shot. Overall, that protection against the Delta variant, particularly with the vaccine, was still close to 90% against preventing symptomatic disease, which I think is very, very encouraging as we're seeing Delta become the predominant virus that's circulating here in the United States. But again, I think this is one more piece of evidence that people need to take into consideration decisions about their vaccine status. I really would highly recommend that everyone ask their health professionals about it if they're hesitant, but really think strongly about getting vaccinated. On the therapeutic front, since the last time I joined you on this briefing, there have been a few developments that continue to show how we're learning more we can take care of patients who do become severely ill with COVID-19. A few weeks ago, the WHO published a large meta-analysis that looked at close to 10,000 patients that had received an IL-6 inhibitor. We've talked in this forum before. It's there these inhibitors that have rheumatologic diseases that can actually shut some pathways of inflammation, and they've been shown in a number of contexts to reduce the likelihood of death and the likelihood of progressing to requiring ICU level care and mechanical ventilation. And this large meta-analysis showed similar results. There was a 13% reduction in overall death and a 28% reduction in the risk of going on a mechanical ventilator. And so we've been using IL-6 inhibitors for several months now as standard of care in patients really ill with COVID. And I think this is another piece of evidence that suggests that they do have an important role to play. So there was some encouraging news out of India. We've been talking about these COVID therapeutics that really require either an IV infusion or actually waiting until you're admitted to a hospitalized environment in order to receive them. There's an antiviral agent called molnupiravir. There's been some preliminary evidence in the US suggesting that it decreases the time that someone will have active viral replication. But there was a press release looking at a phase 3 trial in India that showed that molnupiravir compared to placebo improved how quickly patients recovered from their COVID infection and actually prevented them from going into the hospital. So we're hoping that in the coming months, we may actually have enough data to suggest this is an oral treatment that we could give to patients outside of the hospital to prevent them from getting severely ill or having to come into the hospital. So we continue to learn more. We're still waiting on some of that data, but I think that's some encouraging news on the treatment front. But again, what we really want to focus on at this point. We have a better sense of how to treat people if they do become severely ill to the hospital, but we have better data and better evidence about preventing them from getting sick in the first place. And that's really what I think we need to be focusing on right now.
Thanks so much, Brian. Bill, I'm now going to turn to you. There are a host of concerns about the Delta variant, and it is now the dominant strain in the US. How are vaccines holding up as we see this variant so rapidly spread across the globe?
Yes, and as Brian said, the vaccines are holding up quite well against the Delta variant. I'll discuss in a little bit of detail the evidence and some of the evidence that Brian referred to. But the current vaccines in the United States continue to be highly protective, particularly against severe disease, hospitalization, and death, even with the Delta variant. But this confluence of a more highly transmissible variant such as Delta, communities with low vaccination coverage, and the easing of some public health measures such as indoor masking and distancing has really led to this resurgence in the United States, particularly in some states and some counties, with increases in cases, hospitalizations, and deaths, as Brian described at Johns Hopkins Hospital. And as Brian said, one striking figure is that the vast majority, 97% of hospitalizations are in people who are unvaccinated. And in the face of that, it's quite striking that our vaccination efforts are really stalling. The rates of new vaccination are way down from what they were in early April. And Lainie, as I was preparing for this, kind of looking at the proportions in different age groups of people fully vaccinated, it's only bumped up, a percentage point or so since we last talked 2 weeks ago. So what I thought I would do very briefly today, Lainie, is I just wanted to do some thought experiments, and I'm just going to go through a couple thought experiments. I don't know the answers to all of these, but I thought it would be an interesting way to try to dissect some of these issues. So my first thought experiment is, what would the pandemic look like in the United States if we did not have any of the vaccines? And I think now we kind of take these vaccines, or some of us take these vaccines for granted, but there was no guarantee that a year, even a year and a half into this pandemic, we were going to have such highly safe and effective vaccines. If we look back to what was happening in the United States in January, before we really had a vaccine rollout, we were seeing 250,000 cases a day in early January, with 3,500 deaths a day. It's hard to imagine that right now. That was before the Delta variant, before this more highly contagious variant. What would it look like in the United States now if we had the Delta variant but no vaccines? Could we be up to 500,000 cases per day, close to 7,000 deaths a day? That would be over 200,000 deaths a month. It's hard to predict what this would have looked like, but if we would have been in really dire straits with this Delta variant without vaccines. So the second thought experiment, what would the pandemic look like in the United States right now if coverage in adults older than 18 years of age was the same as that in adults over 65 years of age? I mean, one of the striking things to me is that in adults older than 65 years of age, 80% in the United States are fully immunized. 90% have had at least one dose. What if we had that same coverage in everyone older than 18, or better yet, older than 12? We would be way up near that kind of magical herd immunity threshold. I often am hesitant to talk about herd immunity because it's a much more nuanced concept than we generally talk about it, but it's related to the basic reproductive number of the virus, which is basically on average how many other individuals are infected from a single infectious case. And if we go from the original variant, where that number was it was between 2 and 3, maybe 2.5. Let's just say 2.5. And we think about in our very simple formula, what a herd immunity threshold would correspond to that reproductive number. It's about 60%, and that's why earlier in the pandemic we were talking about that number. Again, the issues are more complex than that. But if you double that for the Delta variant, let's say people talk about a reproductive number of 5 or 6, then you're up to a herd immunity threshold of around 80 or 85%. We're nowhere near that in the United States. But if all adults had the same coverage as those older than 65, we would be close. My third thought experiment: what if our vaccines were less effective than they are against the Delta variant? And this comes back to Brian's point about this publication just this week in the New England Journal of Medicine from Public Health England. So this is from the UK. We'd seen some of these numbers before, but what is quite striking, as Brian pointed out, is the very low vaccine effectiveness with the Pfizer and with the AstraZeneca vaccine with a single dose. For the Pfizer, around 30%. But if you get 2 doses of the Pfizer vaccine, you're up to about 88% effectiveness, even against the Delta variant. That compares to about 94% with the Alpha variant. So a little bit lower, but still a very high protective effectiveness. So what if our vaccines were only working? What if the 2 doses were only working as well as a single dose, where we only had 30% effectiveness against the Delta variant? Well, that would be a very different situation than we're in right now. That's a situation in which we would need booster doses, maybe even a new vaccine that's targeting that Delta variant. But we're not in that situation. We have high protection, high effectiveness against the Delta variant with our current vaccines. Fourth thought experiment, and I know we're short on time. What if the current vaccines receive full FDA approval tomorrow? Lainie, you and I have spoken to individuals who still consider these vaccines experimental because they're under an emergency use authorization. A full FDA approval might sway some people to accepting vaccination, but where I think it would have the bigger impact is on vaccine mandates. It would really allow schools, universities, employers. I think it would give them more freedom for vaccine mandates if we had a full FDA approval. Do I think we need a full FDA approval for mandates? No, and we've discussed this. Johns Hopkins University has a vaccination mandate, but I think it would help. I think it would help move the needle and help us get higher vaccine coverage. And my last one, Lainie, what if there were a financial cost for people who choose not to be vaccinated but end up hospitalized or in Brian's ICU? I'm not suggesting this, but some have. Maybe there should be a financial cost associated with that. Increased insurance premiums, maybe responsible for a higher proportion of their healthcare costs. I know these are very controversial issues, but I think it's worth thinking through some of these as thought experiments. And I'll stop there.
Thanks, Bill. I do enjoy a good Friday thought experiment with you. So thank you for walking us through those. I'm now going to turn to questions that are coming in, and we do have a shortened time for Q&A today, but for our audience, please do continue to submit questions. I'm keeping a close eye on the chat as they come in. Bill, first for you, I don't think there's a number, but can you speak about what we're hearing and increasingly hearing about people who are fully vaccinated getting COVID?
Yes, and this is a really important question. And so, what we're seeing, so I was talking about, studies looking at symptomatic infection and that high effectiveness. We are hearing more reports of what are called breakthrough infections in fully immunized individuals, and that's 2 weeks after the second dose for a Pfizer Moderna, 2 weeks after a single dose for a Johnson and Johnson. What's really important for people to know is that vaccines rarely, if ever, have what we call sterilizing immunity, where they prevent prevent infection. Vaccines act very differently than masks, for example. Masks serve as a barrier. They prevent the virus from getting into our body, from infecting our cells. Vaccines don't do that. The virus can still enter a body. The virus can still infect our cells, and it will if we're fully immunized and exposed to the virus. What happens, the power of the vaccine comes after that point. Once our cells are infected, then our immune system kicks in. It's been primed by the vaccine, and it can fight that infection very early. Now, sometimes it can clear that infection very rapidly before there's much viral replication. But other times there is some viral replication, and it may be, or probably is in part at least, a function of the amount of virus we're exposed to. But there will be some viral replication. Again, vaccines are not perfect. So people have to understand that it's rare for these breakthrough infections, but they're expected with vaccines. Vaccines are not going to completely prevent us from getting infected. And some of those individuals, will have some mild disease. Many are asymptomatic. What the vast majority will not have is severe disease, and requiring hospitalization or even dying. So I think these breakthrough infections are getting a lot of attention, but they are expected. And the big news is that our vaccines are protective against severe disease.
Thanks, Bill. Brian, question for you: as universities contemplate return to campus, return to work, but also places throughout the country are thinking about this and preparing for it, what is your best advice as a frontline provider?
Well, I think as Bill has been mentioning, the best protection both for an individual but also for communities is to be vaccinated. And so we've seen many universities, including our own, have a vaccine mandate in for people who are going to be spending any time at all on campus. And if those individuals are not vaccinated, there are going to be certain requirements to get frequent testing, to wear masks, to practice social distancing. So I think that's important. I think the other thing that's really important is that we all recognize, as Bill was saying, vaccines aren't perfect. There are going to be individuals who may come down with very mild COVID from this. We need to reapproach the way we think about work and school. And when individuals have any symptoms, it could be from COVID, it could be from influenza, we need to create systems in place where people are comfortable raising their hand and saying, I'm not feeling well, without having negative implications, both either for school or for work. We need to create these systems in place so that we can make sure that symptomatic people have the opportunity to raise their hand, get tested, and to make sure that they're not coming to work or coming to school if they're ill. I think that's really going to be a powerful tool. Obviously people can spread viral illnesses before they become symptomatic, but I think we all can think back in our own lives where colleagues have come to work sick, obligations that we felt we needed to attend to, and we weren't feeling our best. I think that attitude, in addition to making sure that people are getting vaccinated for COVID, vaccinated for the flu, and keeping in mind some of these other mitigation methods.
Thanks, Brian. And Bill, I'm going to give you the last word today because we're coming up on 12:30. What do we know about the potential for disease transmission from someone who is fully vaccinated to someone else who is fully vaccinated?
Yes, what we know is that risk is very, very low. It's hard to quantify it because there are many factors that kind of play into this. But I will say, one of the big questions, I think, right now is how infectious are fully vaccinated individuals with the Delta variant, because that's going to be an important one. We do know that individuals infected with the Delta variant have much higher viral loads, and that probably, translates into higher infectivity, and that's probably what's driving that higher infectivity. But we still we're learning more. Actually, I think it's among athletes who are tested very frequently, where a lot of these studies are being done. But all I can say, Lainie, is that the risk of transmission is lower from a vaccinated individual, and the risk of being infected is lower in a vaccinated individual. So that combination of probabilities, if you will, results in a very low risk of transmission from one vaccinated individual to another.
Got it. Thank you, Bill. Since we're at 12:30 now, I'm going to wrap up. I'd like to thank Brian Garibaldi and Bill Moss for joining me today, and give a big thank you to everyone who joined us, and of course to those who submitted questions for our experts to answer. This briefing will be archived and available at coronavirus.jhu.edu. As a reminder, we'll offer these 30-minute briefings regularly on Fridays at 12 p.m. But during the summer, we'll be offering the briefings every few weeks, and that means that our next briefing will be on Friday, August 20th at 12 p.m. As always, in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing, and until then, thanks and stay safe.